Today we'll talk about some things regarding to Achalasia Cardia. So as you can see, manometry is the home ground for diagnosing Achalasia Cardia. So this is a normal manometry. On x-axis you are going to have the length of the esophagus. On the y-axis you are going to have time of the time. So basically, as you all know, whenever you are going to have food, there is going to be passage of the food down the esophagus. As you can see here, the red color represents more amount of contractions and the green color is kind of cool zone where there are the contraction, the pressure of contraction is less. As you can see here, in the initial phase there is some line which is where there is no red or neither there is green color. Here this line typically represents where you have taken the food and the upper esophageal sphincter pressure is actually relaxed to zero. Then as you go down, you can see that the esophagus, the food is going downwards, and as you can see, there is a distal latency, or you can say a distal latency means that after taking food, the time after which it is present in the lower part of the esophagus. So this is called as distal latency. Another thing which you can spot on here is if you are going to take on the z-axis, obviously as on the z-axis there is going to be the pressure index. So as you can see, if you take the square here, and you consider the length, the time and the pressure index, so this total area will be calculated as a new formula or a new value that is called as distal contractile index. Distal contractile index, it basically means the vigor through which the esophagus is going to contract. Okay, so now here in this you can see that as soon as you have swallowed the food, so as I said here you are swallowing the food, here you can swallowing the food. As soon as you have swallowed the food, the lower esophageal sphincter transiently starts relaxing. So this is nothing but distal latency again. So you can see here that normally this esophageal sphincter should relax below the distal latency, and this is termed as IRP. That is nothing but integral relaxing pressure. So they say that most of the times the lower esophageal pathology, so lower esophageal sphincter pathology leads to the upper esophageal motility disorder because the food cannot pass through the lower esophageal sphincter properly. So Achalasia cardia is nothing but a pathology situated in the lower esophageal sphincter. So this achalasia means inability to contract. So achalasia means inability to contract. So the lower esophageal sphincter cannot contract. So as you can see here, LES, the LES cannot contract. Hence you can see the upper distal latency and the DCI, which are located above the IRP, those are also affected in the Achalasia cardia. So according to the Chicago classification, we can. So basically, before going to that, I would like to tell you that in integral relaxing pressure, it should be less than 15 mm of mercury. Normally, you know that the esophagus tone, the tone of the esophagus is in the lower esophageal sphincter is 6 to 26 mmHg. So whenever you are going to have food, this is the normal. So whenever you are going to have food, normally it should reduce to that below 15 millimeter of mercury for smooth passage of the food. So if the IRP is more than 15, then it confirms the diagnosis of Achalasia. So what you are going to do, whenever you get a manometry report, the first thing you are going to see is IRP. So manometry report, the first thing you are going to see is IRP. In IRP, it can either be increased or it can be decreased. So it can be normal or it can be increased. So if it is normal, then you are going to look for the DCI. That is as we saw, distal contractility index. So this is nothing but this area in the square or in the rectangle, it is distal contractile index. Okay, you're right. So if it is positive, then you are going to name it as LES pathology. That is most probably Achalasia. Then what you are going to do here? You are going to check for the contractions of the esophagus. So you are going to check for the contractions of the esophagus. So if contractions are absent, it is classic Achalasia. If the distal latency index turns out to be 0, so I'm saying distal latency means, as you can see here, normally the graph here, there is going to be some amount of delay. When the food is passed from the esophagus to the relaxation of the lower esophageal sphincter, or the food reaches the lower esophagus. That is distal latency. Here the distal latency is going to be 0. I'm going to show you the graphs later on, so you'll get to know what I'm trying to say. The distal latency here will be 0, that is type 2, and type 2 achalasia. So type 2 achalasia, this is type 2. And when there are going to be spasmodic contractions, it is considered to be type 3 achalasia. It is considered to be type 3 achalasia. So I have taught you about type 2 achalasia, classic or type 1 achalasia, and yes, we are seeing type 3 achalasia. If the IRP is normal, and then you are going to look at the DCI. If the DCI is increased, if the DCI is increased, then you are going to call it as diffuse esophageal spasm, or you are going to name it as jackhammer esophagus. So whenever a patient is going to come to you with a non-cardiac chest pain, always remember, though you are of high index of suspicion about esophagus, always rule out first with ECG if the patient is not having any cardiac cause. So once the ECG is ruled out, then you are going to take the patient for manometry. It will tell you the exact cause of the chest pain, if it is due to achalasia, or if it is due to normal IRP with you say DCI problem. So this is how this is. So yes, now before going to that, let's see about the types of achalasia. I've got you the exact new the manometry reports. So as you can see clearly here, there are no peristalsis. So no peristalsis, friends, and that is the reason why I have called this as, yes, it is called as type 1 achalasia. In type 2, you can clearly see that the distal latency, there is no distal latency here. As you can see, normally when this is the point where patient does have food, but as you can see here, there is no distal latency. So distal latency is not going to be present. Normal distance latency is around 4.5 seconds. So the distal latency is not going to be present here, and that is why I name it as type 2. And as you can see, there are generalized peristalsis all over the esophagus. Hence it is called as pan-esophageal pressurization. So there is pan-esophageal pressurization, but there is no peristaltic wave, as you can see here. Now, if you can see in the type 3, there are going to be some spasmodic contractions down there. As you can see here, there are some amount of spasmodic contractions. See the pressure here. It is about 100. So there are spasmodic contractions which are present here. Hence it is called as type 3 achalasia cardia. So normally, according to the management protocol, for type 1 and type 2, a normal modified Heller's would work. But in type 3 achalasia, you need to make sure that you perform Heller's right from the carina, that is almost from the T4. Hence, right from the carina. So as you can see here, hence it is always preferred that in type 1 and type 2, you can go for laparoscopic Heller's myotomy. But in case of type 3, you can go for POEM, per oral endoscopic myotomy, wherein you are going to go within the endoscope and then you are going to puncture the mucosa. So this is your esophagus esophagus outer muscular layer. Then you are going to have the mucosa and the submucosa. So you are going to, what are you going to do? You are going to enter from the endoscope through inside. You are going to go and you are going to ablate the muscle. So this is the way you are going to go. This is called as POEM, per oral endoscopic myotomy. So this is POEM. As you can see here, as we require a lot of seed. So basically, if you can see the length around here, you need to clear the esophagus around here. So you need to perform a high myotomy. Hence a POEM is preferred here. So this is it. A medical management obviously includes calcium channel blockers and nitrates. There is also another method called as balloon dilatation or botulinum. Or these both methods are kind of temporary reliefs which give a relief about 2 to 5 years, and hence these are preferred in the old age fragile patients where the symptoms are present, and it's specifically those who are unfit for surgery. So these methods are temporary methods but are preferred for the patients who are unfit for surgery but require symptomatic relief. So this is it. Stenting is not quite routinely done, and those that do not have some you can say promising results as well. As you can see here, see, this is how the DCI is calculated. So these are quite a few good diagrams which I got from the net. So this is the DCI which we calculate here. So normal DCI should be less than 8,000, and distal latency should be less than 4.5 seconds. So as we saw, distal latency came down in the type 2 Achalasia cardia. Distal contractile index comes down after the IRP is normal. So here we can see jackhammer esophagus. You can see the distal latency index. So on the y-axis, the time has increased. Here you can see the amount of red color has increased. So you can see here 100 to 150. So it might be around somewhere around 125. So you can see that the pressures in the esophagus have increased. So the total DCI value should be more than 8,000. So this is jackhammer esophagus. And in the diffuse esophageal spasm, you can see that there is not much of the increase in the time. As you can see here, there's no much increase in the time, but there is increase in the length of esophageal pressures. So this is termed to be distal esophageal, diffuse esophageal spasm. So this is how you can diagnose these conditions on the basis of manometry. Quite easy, you can say. Once you get a hold of the graph, it's same like ECG. Once you know about the basics of ECG, you can diagnose any conditions on the ECG by using logic. Here's the same thing which can be applied here. Here again, as you can see, distal latency is 3 seconds, so it is obviously less. You can see here, the distal latency is 3 seconds, so it is obviously less. Exactly what they are trying to tell us from this diagram. So I hope this is clear. So this is the length of the esophagus, which is plotted on the, you can say, y-axis. On the z-axis, there is going to be pressure, that is millimeters of mercury. So this is a triphasic graph of x, y, and z-axis. So this is a basic approach and the management to, yes, you can say, Achalasia cardia. So if the patient is having high surgical risk, as I said, old age frail patients, you need to go for botulinum toxin injection first. You can see if there is failure, then you will go for pharmacotherapy, because the study states that pharmacotherapy is not quite effective in these cases. So better to go for a botulinum toxin. If it is successful, then you have to repeat the therapy whenever the patient is symptomatic, maybe after 2 to 5 years. And in low surgical risk, if it is more than 45 years, consider a balloon dilatation first. If success, then repeat. Why? Because after 45 years of age, the esophagus mucosa or the esophageal tissues may become a bit of fragile. Hence, it is always preferred to go for balloon dilatation first. In case of low surgical risk with less than 45 years, we need a permanent cure. Hence, we are going to consider myotomy first. If it fails, then you are going to go for balloon dilatation, or you are going to go for esophagectomy. Just to tell you a few things, initially the myotomy was designed by Heller. It was an open procedure by which there was a midline laparotomy. You can say there was a midline laparotomy done, and then there was cutting of the esophageal mucosa, cutting of the esophagus muscle on the anterior and the posterior aspect. But as you can see later on, what happened is this converted into a minimal access surgery, which is termed as modified Hellers by laparoscopic route. Modified Hellers by lap route. Here obviously we don't cut the muscle on the posterior aspect. What we do is only cut the muscle on the anterior aspect. You can guide it by inserting a bougie inside the esophagus. So we only do anterior myotomy. But in case the anterior myotomy fails, you can just go and approach the esophagus from the POEM approach. And here in POEM approach, you can do a posterior myotomy as well in case it fails. You can go for posterior myotomy. So in case of failure, you can go for posterior myotomy. The studies are still going on to study between POEM and you can say laparoscopic myotomy, but whatever, from now you can prefer any of the routes which the patient is preferring. The only contraindication for per oral endoscopic myotomy is if there is a presence of previous cancer, if there was some conditions like you can say a complete contraindication to general anesthesia, then you might do it under high spinal or epidural. That depends on the patient's condition. So again, quick revision: on the x-axis it is going to be the time, on the y-axis it is going to be the length. Whenever the patient is going to swallow the food, the upper esophageal sphincter, the initial phase of the sphincter is going to give you some amount of less contractions, followed by red color vigorous contractions of the upper esophageal sphincter, with three components which you are going to check, that is integral relaxing pressure, distal latency or distal contractile index, and distal latency. The distal latency is the time to which the lower esophagus contracts after having food and when the food enters there. Integral relaxation pressure is the pressure of the lower esophagus, or you can say the lower esophageal sphincter, whenever you swallow the food. In normal you and me, there should be less pressure in the lower esophagus, that is you can say less than 15 millimeters of mercury. If it is more than 15 after the first swallow, it is considered to be lower esophageal sphincter pathology, which is likely to be Achalasia cardia. Here you can make it into three columns: type 1, type 2, and type 3. Type 1 is classic, where there is no peristalsis present, that you can see no peristalsis. In type 2 achalasia, as you can see here, there is going to be pan-esophageal pressurization, but the pressure is not spasmodic, hence we call it as pan-esophageal pressurization. The most characteristic finding which you are going to see here is the distal latency index, which is going to be less than 4.5. In the type 3, you are going to see spasmodic esophagus contractions, for which you are going to need a high Heller's myotomy. Excellent, we got it till here. Then we are going to prefer a balloon dilatation or a botulinum toxin for the patients who are old age with fragility and who are unfit for surgery, which require repeat after 2 to 5 years. The you can say normal modified Heller's myotomy was anterior as well as posterior, but nowadays we perform a anterior laparoscopic myotomy, and if it fails, we may go for a POEM through a posterior approach. The DCI should be less than 8,000. If it is more than 8,000, you can see according to the you can say the time graph, you can see if it is more than 8,000 with a white time graph, it is jackhammers, and if it is just a simple plain graph with you can say high quality contractions or vigorous contraction, those is called as the diffuse esophageal spasm. The management should be as which is shown in the picture. I hope everything is clear and fit and fine. And yes, this is it for you can say Achalasia cardia. I hope you got to know about the types, about the basic IRPs, DCIs, and distal latencies. So if you have any doubts, you may contact me. Thank you. Thanks a lot for watching this lecture.